Good morning, everyone. Give it one more minute, and then we'll get started. Hi, Dr. Sisson.
Good morning.
Thank you for being here. Good.
Happy to be here.
All right. We have most folks on the call. Okay. So good morning, everyone. Thank you for joining us for day 2 of the Future of Medicine virtual program. Again, my name is Sam Mello. I'm the program manager here at the Medical Society. Before we get started, I wanted to go over some of the expectations and reminders. Just you had them on Monday, but I'm going to go over them one more time. Please make sure your full name is on your Zoom profile. I can't count your attendance unless I can see your full name on your Zoom. You're welcome to have your cameras on. We'd love to see your faces. And so please do as much as you can. It's much nicer for our speakers to talk to faces than just blank screens. Please be respectful and attentive to our speakers, staff, and fellow students. Rude language, bullying, and inappropriate behavior will not be tolerated. Violating these rules may result in expulsion from the program. Please keep yourself muted when not speaking. You can use the chat function to ask or answer questions. If you'd like to speak, you can use the raise hand function, and we will call on you to speak. We will try to get to all of your questions, time permitting. So without further ado, I wanted to introduce Dr. Aimee Sisson. Dr. Sisson is the Public Health Officer for Yolo County. So she's going to talk a little bit about public health careers. Welcome, Dr. Sisson.
Thank you, Sam, and good morning, everybody. Sorry, I was just peeking out the front window because my dog is hanging out outside and misbehaving a little bit. So if you see me ducking down, it's only to check on her. But thank you for having me this morning. Thank you for being here. As Sam mentioned, I'm Dr. Aimee Sisson. I'm the health officer for Yolo County. And this morning, I want this to be really informal and just talk a little bit about who I am, what is a health officer, what is it that I do, how did I get here, what is sort of a day like as a health officer, and then to answer any questions that you guys have, and hopefully make this a little bit interactive, because I know it's not fun to just be talked at, especially early in the morning. I know I'm not a morning person. So let me start by saying a little bit about what it is that I do. I am a health officer, but first and foremost, I'm a physician and a public health doctor, which is very different from a typical physician who works directly one-on-one in an office or in a hospital with patients. I work with populations. So as the health officer for Yolo County, there's 225,000 people who live in Yolo County. And I'm really responsible for the health of every person who's living in Yolo County. I don't take care of them directly, but I shape policies and make decisions that can impact the health of everybody living in the county. So it's kind of a big responsibility, but it's also very exciting because I have the opportunity to have a big impact instead of, maybe seeing 20 patients a day in 15-minute increments, like a lot of outpatient care providers. When I work, it has the potential to impact every single person who works in the county, or who lives or visits the county. So for me, that's very exciting and makes the work that I do rewarding. I think the other thing that's unique, maybe not unique, but different about public health doctors is that we're really focused on prevention. So a lot of other types of medicine are about treating people once they're already sick. And public health and the specialty that I'm certified in, preventive medicine, are all about keeping people from getting sick in the first place. So it's about preventing disease, preventing complications of disease, and also promoting health, because we know from the World Health Organization that health is more than just the absence of disease. It's also the promotion of wellness and complete physical, social, and mental well-being. So it's kind of a different model, really focused on prevention and keeping people healthy, preventing them from getting sick in the first place. And I want to, engage you guys in thinking a little bit about this concept of keeping people from getting sick in the first place. And that can be things that are provided in doctors' offices, medical care settings. But it turns out that, when we look at people who are getting sick and who are dying, prematurely before their time, so to speak, only about 10% of that is determined by what happens in healthcare, the interaction between an individual patient and a provider, physical therapists, doctors, nurses. And about 30% of people dying early is related to our genetics. But then there's this other 60% that's out there. And a lot of that is determined by the environment that we live in. And so I just, maybe take a couple minutes. We can, you can raise your hand or just come off mute and think about like where you live. And like, if you had a chance to choose like an ideal community to live in that would promote your health, like what are the things that community would have in it? Because those are really what determine this other 60% of our health. So I'm just curious. Yeah, go ahead, Jody.
I feel like the most important thing would be having a place abundant in like natural resources. Maybe so there's a lot of trees that could help with your mental health, but also just having access to food and water in general.
Yeah, so you've gotten at a lot of things, green space, um, for aesthetics, but also, green space and trees, they also help with air quality, which is important for our health. And then you also mentioned, access to new food, and that certainly plays a big part. For example, if you lived in a neighborhood that doesn't have a grocery store and all you have is fast food restaurants, that's going to impact the decisions that you make about the food that you put in your body. Aria.
I think another thing that's really important is also like living in a community where you feel safe. Because, yeah, then, you won't be like stressed out and anxious all the time. And that plays a really big part in health.
Absolutely. Safety is a key part of a healthy community. And that's not just physical safety, but also psychological safety. Do you feel included? Do you feel connected to others, as well as like do you physically feel safe that you're not going to be harmed? Yeah, Harsimran?
One thing I also think of is like good infrastructure as well as like safe driving laws. Because I feel like with like a lot of natural disasters, having good infrastructure is what could prevent lots of deaths. And then driving is what we do regularly. And if you don't have safe driving laws, then car accidents, and that's how more people die.
Yeah, absolutely. Thanks for bringing up the infrastructure piece in so many ways, but you specifically brought up transportation, and we often think about, um, in public health, we talk about active transportation, which is opportunities for people to walk, bike, or take public transit to places where they need to go, as opposed to having to drive in a car. So that's like, are there sidewalks in a neighborhood? Are there protected bike lanes? Those are good examples, but also just in general, like driving laws, the fact that we require seatbelts in the United States, like that is also, those policies play a big role in our health. And we'll go back to Jody, and then I think we'll move on. But thank you guys so much for engaging. Yeah, go ahead, Jody.
So this is gonna expand on the transportation thing, but I think having the ability to physically interact with family and friends is a big help to people's mental health, because with technology nowadays, you can interact with them with video and phone call, but it's just not the same as having them in your community and be able to go to them maybe like with a 1 hour or less drive.
Yeah, no, I agree. I think we often forget how much that social connectedness, social connection, particularly in person, is important. And I think many of us got a strong reminder of that during the pandemic. And I'm going to talk more about COVID because I was very, very involved in the response to COVID as a health officer. But certainly one of the unintended consequences of asking people to stay physically apart was it was harder for them to feel connected, even as you pointed out, while we had these technologies that can help us virtually connect, it's not really the same as getting a hug and sitting next to somebody or face to face and having a conversation. So yeah, so what we've just kind of scratched the surface of the, these are actually called determinants of health. Sometimes people call them social determinants of health, but they're all the things that shape the environments that impact the decisions that we make every day, what food we put in our bodies, how we get from one place to another, whether we feel safe. All of that is that other 60% of what determines our health. And we often focus on, health care. And, for those of you who are, you're in this program because you're thinking about medicine, I just encourage you to think a little bit bigger, and opportunities to impact things, upstream, preventing disease, thinking about, what are the ways in which we can shape the environments in which people live to make them healthier. So thank you for engaging in that exercise. That's a lot of what I get to do as a health officer, is that sort of thinking about what are ways that we can shape our communities so that the people in them are healthier. That isn't just about, colonoscopies and mammograms, which are important clinical interventions for prevention, but there's so much more big picture, what we call upstream things that we can do. So I'm going to talk a little bit more about the path that I took to get where I am, and it's a relatively straightforward path until I went into public health. But when I was growing up, I was very interested in science, and I was also enjoyed interacting with people, and someone suggested that medicine is a way to combine the two of those, and so I was very interested in becoming a doctor. I read lots of books about being a doctor and becoming a doctor, even some like novels that were about physicians and epidemiologists investigating outbreaks, because that was one piece that I was really interested in. And so after high school, went to 4 years of college where I studied biochemistry. Not necessary to study a science in order to go to medical school, but it was just something that I was very interested in. But I certainly had plenty of classmates in medical school who, majored in non-sciencey things. One of my good friends was, I think, a philosophy major as an undergraduate. So lots of opportunities there, but certain courses that everybody has to take in order to get into medical school, and it does involve some math and sciences. And then 4 years of medical school, I went to UCLA, or the University of California, Los Angeles. And when I first went to medical school, I thought I wanted to be a family doctor or an internal medicine specialist, maybe a cardiologist, because I had a few experiences there. But it turned out I really loved anatomy. I surprised myself, and I had a mentor who was a surgeon, and I was very interested in surgery. So after medical school, I actually did a year of training, my internship as a surgeon, and realized that I liked it, but I didn't love it. And, I was working 80 plus hours a week, and I was like, life is too short to spend 80 hours a week doing something that you don't truly love. And so I took a step back and thought a little bit more, and remembered that it was public health and like reading about these epidemiologists who were investigating Ebola outbreaks that had gotten me interested in medicine in the first place. And so I sort of put pause on my taking care of patients and decided to go back to school and get a master's in public health, which I did right down the street here in Davis at UC Davis, and then learned about the specialty that I'm now board certified in, which was general preventive medicine and public health. I had no idea that existed. And so part of why I'm here today is to tell people, tell all of you that, if you're interested in medicine, there is this different route that involves working with populations, and not necessarily focused on individuals, because you have an opportunity to have a big impact on a lot of people. And so I got my master's in public health, learned about preventive medicine as a specialty, did another year of residency actually at the state health department and at a local health department, and then got a job working for the state health department, California Department of Public Health. And I was there for about 10 years doing chronic disease, things like heart disease and cancer prevention, some work in climate change and healthy communities. I did some work on mental health as well. And then I had I needed to do something different. I got very interested in food and you know, having healthy, affordable food available, and I started gardening. And then that sort of expanded to the point where I wanted to learn how to grow food on a bigger scale. So I actually took a little bit of a break from the office job and apprenticed on a farm for a couple of years, and worked part-time at the health department and part-time apprenticing on an organic farm and then running my own farm. And it turns out farming is awesome, and I couldn't make a lot of money doing it. And so I ended up coming back to public health work full time. And then I had an opportunity to come to the local level where I had done some of my training, and as a local health officer in Placer County, and that was in October of 2019. And I was just learning how to do the job as a local health officer, and this thing happened called COVID. And so I was, you know, very new, still getting to know everybody, had never even like presented to the board of supervisors, which are, you know, essentially my bosses as a health officer. And then all of a sudden we had a COVID case and we had a person who died of COVID. And I was, you know, presenting to a bunch of people I'd never met before and doing press conferences and really just getting thrown into the middle of something that I wasn't really ready for. But it was scary. It was fast paced. It was long hours. But it was also, so it was the hardest thing that I've ever done in my career, like being in charge of a county's COVID response. But it was also, and you know, I really hope we don't have another pandemic. We can talk a little bit about bird flu, and you know, some of its pandemic potential. But I think, you know, the work that I did during COVID, like making decisions about, you know, how we needed to respond, whether people needed to stay home, whether we needed to close restaurants and businesses and schools, whether people needed to wear masks, how we could protect, you know, vulnerable people in nursing homes. Hardest thing I've ever done, but also the most rewarding thing I've ever done, because I feel like collectively across the state of California and across the United States, that health officers as a collective, you know, saved hundreds of thousands, if not millions of lives through our actions. And not everybody agreed with everything that we did. And in hindsight, which is always 2020, I think some of us would have made different decisions, knowing what we know now. But the fact of the matter is we knew what we knew then. And in public health, we often, you know, we follow something called the precautionary principle, which basically means we err on the side of caution. If we're not sure, then we're going to be cautious and protect people. And then when we learn more, we can loosen those restrictions. So that's kind of my story of how I got to be a health officer. And I've talked a little bit about what a health officer does in terms of, you know, being responsible for the health of an entire community. And I think many people, and you know, raise your hand if you ever heard of a health officer before the COVID-19 pandemic. Jody, all right, one person out of, how many people are on this call? 2 people out of 37. I won't count Sam and myself. So 2 out of 35. Really, hardly anyone had heard of a health officer. Raise your hand if before today you'd ever heard of a health officer. Yeah, seeing a lot of real hands going up for people who have their cameras on. And a lot more virtual hands. So yeah, I think it was really the pandemic where most people in the general public started hearing about health officers. I'm like, who are these people who are making these decisions about what I can and cannot do? And so, we're physicians, doctors, who care about keeping people healthy, and have actually been given a fair amount of authority and power to do so. But with power comes responsibility, and I think all of us, speaking for my colleagues across, there's 61 local health jurisdictions in California, all 58 counties, and then 3 cities have local health departments and local health officers. And we don't take our authority lightly, and making decisions, ordering people to do things as opposed to making recommendations is something we think really long and hard about. Like, is this what we need to do? Would we be better off just advising people like, hey, here are the risks, you're adults, you can make your own decisions, versus this is something that isn't just about you as an individual, because your decision impacts others in terms of the spread of an infectious disease. And so, trying to find that line of, as much as possible, just making recommendations, but in some cases really having to say, no, nobody can do that, or everybody has to do this, like in the case of a vaccine mandate, for example. So that's just a little bit about, what I do as a health officer. A lot of it revolves, certainly over the last 4 years has revolved around COVID-19, a lot of other work in infectious diseases like tuberculosis, like seasonal influenza, now, thinking about pandemic influenza and bird flu. Also, sexually transmitted infections, we're seeing an increase in those in California as well. So I spend a lot of time on infectious disease, but also, as health officer, it's not just about keeping people safe from infectious disease, but it's also thinking about, how our communities are built, and the policies that we have in place, the physical environments that we have, that can promote or get in the way of health, and trying to take steps and work with others. One of my mentors in public health very early on always talked about public health being a team sport. And, I, as a health officer working alone, can't really get anything done. I work with partners on my team at the health department, but also, if we want to do something about sidewalks in a community, then we need to be working with the transportation agency. If we're, worried about there's too many fast food restaurants and not enough grocery stores, then, we're working with the planning department to think about zoning and what's allowed, and the incentives for various businesses to operate. So that's just a little bit about what I do. In summary, because I want to leave some time for questions, I'll just say that I love my job. It's hard. It's been very challenging for the last 4 years, and it's also very rewarding, because I do feel like the work that I do makes a difference, and I'm able to see that, particularly with the pandemic, but even now on a day-to-day basis, working with patients with tuberculosis, for example, and getting them care, and finding, housing for them when they're homeless, and, can't be out on the streets because they might be infecting other people. Like, the work that my team and I do makes a difference every day. And yeah, it's not easy. We can't please everybody. There's a lot of politics involved, and we often don't have enough money to do the work that we want to do. But on the whole, I find it really rewarding, and I hope some of you will consider it as you move forward. With your interest in medicine, remember preventive medicine and public health. And I'll stop there. And it looks like we have one question already. Sam, I don't know if you want to facilitate, or if you just want me to call on folks.
You can call. Yeah, you can call
All
on
right.
them.
And apologize if I mispronounce names, but Advik? Go ahead and come off mute. Uh-oh. Might have done what I often do, which is click leave instead of unmute. So hopefully they'll be back. Anyone else with questions? Oh, your hand stayed up. Oh, okay, gotcha. That was a holdover from earlier. Any questions? Sukita, is that a real hand I see?
So my question is in what you do as a health officer, does it revolve like you mentioned that you do a lot of like you still help people in a way like even though you're not are you like in a hospital environment or are you like working like just virtual with like people just like work with how this disease became like bad and stuff?
Yeah, that's a great question. Where do I work? You can probably see behind me today. It's blurred, but I'm at home. I'm able to work from home a couple days a week, and when I'm not at home, I'm in an office, but it's usually on a computer. I do a lot of email. I do a lot of meetings on Zoom or in person. And so I'm not usually in a patient care setting, although, sometimes I end up. We had, for example, a tuberculosis patient who was leaving the hospital against medical advice when they needed to be in respiratory isolation. So I ended up outside the hospital talking them into staying. But typically I'm in my office at a desk behind a computer, but definitely interacting with people. And I do a fair amount of presenting on Zoom calls, but also in-person meetings, sometimes testifying before the legislature about the budget. So I get out and about in the community, but not typically in a hospital or in a clinic setting. Let's go to Jody and then to Sneha.
I have a question. So, what occupations do you usually work with? Is it just like public health in general with other public health officers, or do you also work with people in the clinical setting?
So it's a little bit of both. I'm not physically in a clinical setting, but I'm often interacting with providers who are. For example, as the tuberculosis controller, or really I'm the communicable disease controller for all of Yolo County as well. So there are certain diseases that providers are required to report to the health department, and sometimes they'll submit a report, but we'll have additional questions. And so I'm calling up those providers and having a conversation about the patient. I sort of the area that I get the most involved in care is the patients who have tuberculosis, active tuberculosis, because that's infectious towards others. And it's relatively uncommon. We get about 6 cases a year, and so I'm often consulting with the providers about what treatment protocols, as well as plans, and what are the next steps needed to either clear somebody from isolation or to determine if they have active tuberculosis. I also meet regularly with our hospitals to talk about what some of their issues are, to talk about what we're seeing in the wastewater and what percentage of their patients are testing positive for flu or COVID. And I also meet regularly with the physicians who are responsible for the clinic systems. So like UC Davis Health, Kaiser, Sutter, Dignity, are Communicare, community clinics that we have, and talking about what are the things that they're seeing, how can the health department help, how can they help us get our messages out into the public. So there's a lot of interaction with providers, but it again is usually outside of the clinical setting, where we're meeting in a meeting room, or over Zoom, but not in a clinic or in a hospital. Sneha,
Thank you.
you're still muted. There you go.
Yeah. Hi. So I was wondering if you can like give an overview of like what are the most important skills for like succeeding in this career field.
Most important tools for succeeding?
Yeah, kind of like important skills.
Sorry, I didn't hear that last piece.
Like important skills.
Important skills. Sorry, I hope I'm hearing you correctly. I think it's a lot. I mean, there's the basic knowledge of medicine and public health, but a lot of what I do is interacting with people and influencing people, and forming partnerships, and like I said, public health being a team sport. And so I think a really important skill is communication, communication with others. Listening. I love the expression, you have, 2 ears and 1 mouth, to be used in that proportion. So listening more than you talk, which, I haven't been able to do in this last half hour with you because it's me presenting, but in general, you'll find me in a meeting doing a lot of listening and taking notes, and then, speaking when I need to, but really wanting to hear the opinions of others, and then trying to figure out how to weave those together into an approach that'll work for everybody. So I would put communication up there as a really important skill that, everyone thinks about medicine and, science, but I think, being able to talk with people is a really important skill.
Thank you. That was a really great answer.
And I think we have time for one more question. So I'm sorry, I've probably mispronounced everybody's name, but Ms. Sayer?
Oh yeah, so if I had a question, so if public health officers are the ones who create the policies, then who ultimately decides whether those policies get put into place or not?
Yeah, that's a great question, and it depends. In some cases, the health officer is the decider. I mentioned having a fair amount of power, particularly when it comes to communicable disease. So the health and safety code, the laws in California allow the health officer to do basically whatever we think is appropriate to control the spread of communicable disease when there's an emergency. So that's a lot of power. Typically, that's somewhat checked by the Board of Supervisors. Health officer orders don't necessarily have to be approved by anybody except for the health officer. But again, this is a team sport, and if you're not playing well with others, you're probably not going to stick around for very long. So when I'm making decisions that come out as orders, I'm talking to our county lawyer, like, hey, does this seem like a reasonable thing? Is it legal? Is there another way we can accomplish this? And also letting the 5 members of our county board of supervisors who are elected officials know, like, this is what we're planning. Do you have any concerns? And then there's other parts of my job where we're influencing policies. There are bills that are being put forward by the legislature here in California and weighing in on, like, hey, that's a good bill, but could you please change this language so it makes a little bit more sense? Or, like, we have a concern about this piece. So that's another way that we can influence policy. And so it really just depends on whether it's local or state level, and whether, it's an emergency and I have to invoke some of my powers. What I will say is there are some, just like with our federal government, where we have checks and balances between the different branches of government. We have some of that as well with health officers and boards of supervisors. So if, for example, we have another pandemic and there's I have to declare a local health emergency because, several people have come down with a mystery illness and they're passing it from one person to another, and we need to take action quickly to protect folks. I can declare a local health emergency as a health officer, but it only stands for 7 days until the Board of Supervisors reviews it and decides, like, yes, we agree, or Dr. Sisson, sorry, that was actually a terrible idea and we're going to overrule you. So there is that check and balance in the process.
Okay, thanks.
Well, thank you very much, Dr. Sisson. That was a great overview of a career I know that not a lot of people think about, as you saw, with not many hands coming up, of realizing that that's a career path. So thank you so much for sharing that, and have a wonderful rest of your day. And we'll move on to our next speaker.
All right. Thank you all so much. Take care.
Thanks. All right. Well, up next, we're going to talk to a surgeon. So Dr. Anamaria Robles is an assistant professor at the Department of Surgery at UC Davis Health. She specializes in trauma and acute care surgery. So please welcome Dr. Robles.
Hello, everybody. Welcome. I'm Dr. Robles. Nice to be here. Nice to talk to you guys. I was going to show some pictures and talk a little bit about my journey to surgery and to trauma surgery specifically and kind of how I got there. So let me bring up my slides if I can. Yes. I want this one. So let me see if you guys can see it. Great.
Good.
Looks good. Perfect. So I'll tell you a little bit about me. This is kind of a fun, different talk for me because usually when I'm talking to people, I'm talking about like a body part or an illness or a process. And so I'll tell you a little bit about my journey. Tell me if you have questions as you see them. So like I said, I'm Anamaria. I actually grew up in San Diego, California. I'm the oldest daughter of 2 kids in my family. My dad is an immigrant from Mexico. He came to the US from Sonora when he was 12 years old with the rest of his family. He served in the Army after high school and eventually settled in San Diego. He lived in Los Angeles for a while. My mom is a white American, as you see. She is a daughter of a farmer from the Midwest, who also their whole family served in the Navy. So I have lots of kind of military connections, as I know a lot of you guys do. That's how we ended up in San Diego because they served in the Navy. Based on the stories that my parents told me, at least, like they didn't really have it easy growing up, being from 2 different cultures, especially when they got together. But I've been very lucky to certainly grow up in a loving and supportive family. My family is not like rich in money or connections or pedigree, but we're certainly very lucky in that I've had the love and support of them, even if I've done stuff that they themselves, they don't really understand it, but they have had my back 100% kind of the entire way, which has been, I think, a real foundation for being successful. So I'll tell you a little bit more about my process in schooling to get here. So I went to high school. This top picture with me in blue is when I graduated high school, and then this bottom one is graduating undergrad. I should put my med school one up here. It's a lot of graduations. So I went to high school at San Diego High School. This is, it's a big public school in downtown San Diego. It's considered a poor school, inner city. It's like more than 75% Latino, mainly Mexican American, and has a really high dropout rate. So we started I think with 800 in my freshman class, and we graduated less than 400. So over 50% of my class didn't finish high school. Despite this, I got a great education there. I did well in school. And I think one of the hard things about high school for me was that I felt like the environment had low expectations for me as a Mexican American woman, like everyone was expecting me to kind of do poorly because of those things. And I think it's really hard when people's expectations don't fit kind of where you are and what you expect out of your life. So at the time, I thought I wanted to be a doctor, even very early on, but I had like no idea how to get there whatsoever, like what that process would look like. And I didn't know anybody that had done it. I did know I wanted to go to college, and I was the first person in my family to go to college. I went to Cal. This is me playing rugby at Cal. It's just, I did that for 2 years. It was fun, but then I had to like focus more on my school. I knew I wanted to go to college. I wanted to get some space from my family. I wanted to like figure out kind of who I was. So I had lots of good options. I had got lots of help when I was applying from people in my high school. And I got to go to UC Berkeley for my undergraduate education. So I went to Cal. I was over in the East Bay. And I won't lie to you, Cal was really hard. It's a huge school. There's like 32,000 undergraduates. It was very competitive. I got lost because there was like lots of decisions. People are expecting to make decisions about classes and majors and extracurriculars and like financial aids, and my family and friends like couldn't really help out with a lot of it. So I often I felt bad because others had more resources and sometimes more self-confidence than I did. And it's just hard to feel like you're good enough to be there. But I did figure out how to get a supportive community to help me, and I was able to actually major in science at Cal, which I think was really helpful. Like every college has this. Every college has mentors and people that want to help you. And I think finding those is one of the real key things to be successful in college. Without those people, I would not have made it because it was really, really hard to get through that. But people want to help you. People want you to be successful. So that ended up being, I think, a good experience. But after college, I wasn't really sure still how to get to becoming a doctor. I'd figured out okay, this is how I can get my degree, but what does being a doctor mean? What does it look like? What does that life look like? So I got a job finishing college. I worked at Oakland Children's Hospital, and I was a clinical research coordinator in cystic fibrosis. So I was working with kids. I was close by where I'd been living, earning money because it's expensive to apply for medical school and take the MCAT and all of those things. So I worked that job for 2 years, studied for the MCAT, worked to figure out how to get my application and kind of work around doctors and figure out yeah, this was something I wanted to do. So then I went to medical school, and then you can kind of see the path here. It takes time, especially in surgery, which is longer than the medicine paths. So after college, which was 4 years, I then went to med school, which I did at University of California, San Francisco. That's another 4 years. In med school, there's a bunch of tests you take to get your MD. There's all these steps, and then you get the chance to figure out what kind of a doctor do I want to be in medical school? Do I want to be a pediatrician? Do I want to be an obstetrician? Do I want to be a surgeon? And I initially thought I really wanted to be an obstetrician. I eventually kind of decided maybe I want to be a surgeon. So then you apply to something called residency. And residency comes after med school. So you get your MD degree, but then you have to learn what does it actually mean to be a doctor and how do you work at being a doctor? So you're a trainee there. I stayed in San Francisco. I was lucky to stay there for my general surgery residency. And surgery is a long time. The residency in San Francisco is 7 years. So I spent 7 years after spending my 4 years in med school there training in general surgery. That includes that intern year that if you guys watch Grey's Anatomy or heard of other things, that's your first year of residency is your intern year. After that, I still think I didn't want to just be a general surgeon. I wanted to learn how to be a trauma doctor and an ICU doctor that takes care of surgical patients. So then I did even more, and I did my fellowship, and that's when I came out here to Davis for the first time. So I did my fellowship, which was 2 years in trauma, acute care surgery, which really means emergency surgery, and surgical critical care, which is taking care of patients in our ICU here at UC Davis. I finished that in 2022. And I have been here I got hired as faculty as my first job 2 years ago. So I'm finishing up my second year here as faculty. For reference, I graduated high school in 2003. So it was 20 years of training to get here. Totally worth it. When you think about what you're expected to do at the end of all of this, which is open somebody's body and save their life, you're could I make this a 50-year residency, right? There's always something to learn. But it has been certainly a process for me. It does not take this long depending on the type of thing you want to do in medicine, but it can. And that's okay because you're learning and you're growing the whole time. So that's a little bit about kind of my path and where I went. When I think about why I wanted to do this, you might be why in the world would anyone want to do this? That's a really long time. Sometimes my family is why in the world would you want to do this? Sometimes I still I think it's being a physician, working with people, being a nurse, being somebody that works in the hospital. It's really, it's a vocation for a lot of reasons. The human body is the coolest thing in the world. And we get the chance working in the hospital, being doctors, nurses, respiratory therapists, physical therapists, we get the chance to take care of people and help them. And particularly if you think about trauma surgery and emergency surgery during the absolute worst days of their lives, right? It's a total privilege to be there for people and an honor when they're going through that. Because they let you into their lives in a real way, and you hopefully help them get through what's going to be the most difficult hours, right? They didn't set out that Tuesday morning to get in a horrible car crash, and now their life has changed, and you're the person that's there that's trying to help them through it. So I think that is really important and can be something that helps drive you through those nights of trying to learn and study. Let me just check on my time. Okay. How did I choose my specialty? So my specialty is surgery. You can see some pictures of me here doing surgery, working in the hospital. And these are all pictures of when I was a resident. So initially I said I wanted to be an obstetrician. I went to med school thinking that would be my path. I Partly being a Latina woman that grew up in San Diego in the inner city, you know, believe really strongly in social justice. I believe very strongly in the rights of women. I thought that was going to be how I was going to channel that work. Then I rotated in trauma surgery and I loved it. And it was the same kind of thing. I'm here for a community that needs me, and I'm here for a community that I identify with, that I feel like is my people. And it was also super exciting to think like I can take care of anybody that comes in the door. The trauma community is very underserved, and being there was one of the first times in med school where I felt like, you know, I'm taking care of my people. So that's kind of how I ended up in trauma. These are some pictures of the day-to-day job. So the day-to-day job changes a lot depending on what I'm doing, because I work in all three of those things. So if I am on trauma during the week, we do weeks of service. So I'll show up in the morning, and depending on which team I'm on, I take the trauma phone, which means I get to respond to all the emergency activations and take all the transfer center phone calls from all around the region of Northern California, people asking for help, hoping they can send their patients to us at UC Davis, because we are the region's only level 1 adult and pediatric trauma center, which means we take care of the sickest of the sick. I go see patients in the hospital. I do surgeries on them if they need them. Similar thing if I'm on general surgery, but instead most of the time I'm getting phone calls from the emergency department and other patients in the hospital saying like, does this person need a surgery? I'm worried about them. Doing surgeries on those patients. When in the ICU, it's a little bit different. Not that much different. We usually have it's slightly less patients, but they're very sick. Go around with the ICU fellows and the teams, talk about the patients, make plans, talk to other teams, figure out who needs surgeries, talk to the families, see if they're updated on their loved ones. So at any given time, somebody can get really sick, and then everybody kind of drops what they're doing and goes to take care of them. And we have a great team of people here that all works together. So last week I was on the general surgery call at night, and my partner on trauma got something we call a mass casualty incident, where like an entire car full of people came in all sick, and we needed like 6 surgeons at the same time. And so we all responded to help out, to figure out, you know, when you get 6 people all at once, like you're not necessarily ready for all of them to be ill. And so I went down and we helped, and we saw like 40 trauma patients that night between all of those things. So we're always there to help and helping each other out. So we gathered together, and I worked with tons of other doctors, which is really great as part of being a trauma surgeon. Mainly I operate on patients in the belly and the chest, but I get to work with the neurosurgeons and brain injuries, plastic surgeons, ear, nose, and throat doctors, orthopedic surgeons, because lots of people break their bones, vascular surgeons. We all work together kind of how to figure out how to help people heal after injury. When I think about some of the challenges on this journey, it's hard. It takes a long time. And there are lots of hurdles to jump, as you've kind of seen. There's always another test. There's always another school and applications, and I'm still doing applications, and I still have more tests, and I still have more things to do. And to some degree, you just have to love it, so that when you study, you're studying for your patients. You know, you're studying to be a better doctor, to take care of them, not just to get a grade. You're keeping your kind of true north in mind. And the hours are long. It's a long process, and it is not as glamorous of a job as it looks on television. You can see how tired I was during this whole thing. I think it can also be extra hard if, say, you are like me and from a family where it's not like your dad was a physician, or your mom was a physician, or your grandpa was a physician. It's hard to sometimes feel like you belong, because your background's different than a lot of the people that you trained with. Every other person in my residency program, it was 7. Every other person's parent was a doctor except for mine. And I will say nobody in my family totally understands what they do, but they wholeheartedly, fully support me. And so I feel like that has helped me figure out how to do it. When I think about who's inspired me, definitely the people that have trained me. These are some like bobbleheads from the people that trained me at San Francisco General Hospital. This guy up in the corner, sometimes he's on the news. He's Dr. Andre Campbell. He's the person that made me want to be a trauma surgeon. He's one of the most remarkable people I've worked with. My family certainly inspires me. My co-residents inspire me. Both of my grandparents died when I was in med school and in residency, but getting to see me do that, neither one of them having even finished high school, was like really awesome. And then your coworkers. And then also the other thing that inspires me is my family. I got married in residency, and in fellowship, I had my daughter, and she certainly like helps me be a better doctor because she helps me stay grounded in what matters, right? Taking care of people, being there for people when things matter, being a good person, both for myself, my colleagues, and my patients. So I think those things are really important. I think that was my last slideshow. I'll leave it at this one. So questions that you guys have for me about trauma surgery. Jody, I see a hand.
Yeah, I have a question. So, how often are you actually doing surgeries a day, and how much time in between do you have between each surgery, I guess?
Great question. So in residency, you do probably 2 to 3 a day, depending on the rotation you're on. That is, if you're on colorectal surgery or you're on cardiothoracic, maybe it's 1 a day. It depends. For me on trauma, it really varies based on how sick people are. So it can be during the day, it can be none, it can be 2 or 3, probably usually overnight. I would say 2 or 3 is probably the max of what we can fit in. And if you need to do more, then we just call in backup and we keep going. I'm on service, so I'm the sort of responsible person for a trauma team, usually 2 weeks a month, and then I take 3 to 4 night calls a month. So that's where I'm on from like 4 p.m. to 8 a.m. So trauma doesn't just happen during 9 to 5. Sadly, it happens a lot at night. So we get a lot of opportunity to work with people there. I see so many hands. Elena.
So I know that like, during residency and like all these surgeries, they're like, stressful and just how do you deal with that? Like, is there anything you or your colleagues do that helps you prepare yourself
Yeah.
for dealing with these things?
For sure. It's physically hard sometimes, right? Because you're standing for a long time and you can't eat. And sometimes you're like, I got to go to the bathroom. So some of it is you learn how to help take care of yourself and what things you need to do to be well outside of the operating room to make sure you're well inside of the operating room. As much sleep, exercise, etc. I think the emotional toll of the stress of it, some of that is from talking to one another, making sure you're really prepared for whatever you're going to do. When things don't go well, we also have different processes that we work through together where we talk about, this is what could have gone better. We have M&M processes that we talk about formally in a group about things that we could do differently. But then also a lot of that is being together, being in a residency program, knowing those are the people you can rely on to kind of share all of those experiences. I think that is the most helpful thing, honestly, having the people that you can be like, this went bad, and they're like, oh man, I know how that feels. And you can kind of sit with it together and then figure out how you're going to kind of help recover. Maria.
What do you think was the hardest part of medical school?
Hardest part of medical school. Hardest part of medical school for me, the 3rd year is your clerkship year. So that's your figuring out what kind of a doctor you want to be. So you do like 8 weeks of medicine, 8 weeks of surgery, 6 weeks. This was at UCSF. It's a little different everywhere. 6 weeks of OB-GYN, 4 weeks of pediatrics. You kind of go around and try on everything. I found it really hard to do the things that just didn't suit me well. Like I tried really, really hard I did not do great in psychiatry. I tried really, really hard. It just wasn't quite my thing. And I felt like I wasn't good at it. And that was really hard because it just, when you're good at something and you're flying, you're like, this is great. Time is flying. And then when you are trying and you are just, it's not like your area of expertise, or it's not going to be your area of expertise, but you have to do it because you have to learn some stuff. That was really hard on me, doing the things where I knew I wouldn't do them forever, but I needed to learn, and it just didn't fit me, which is great. We need lots of different types of doctors. We need awesome psychiatrists too, which are different than surgeons. We need everybody. Sneha.
I was wondering, like, what do you find most rewarding in your job, like in your residency or like in your job?
I think the most rewarding thing is when patients and families start doing better, when they start to realize that they're going to go home and maybe it's going to be different than what home was before because now they've had a surgery or this injury or they've broken things and need to figure that out. But once they start to believe that they're getting better and kind of turning the corner, that is super rewarding. Julian.
Hi, I have a question. Was there any, because you had a long time when you went from like high school all the way to like, becoming a surgeon. Was there anything that, like, or like any mistakes that you wish you could like do over again, or like you wish you would have done differently?
Oh, tons. So many. So many mistakes. But everything gets you where you're going, right? No matter kind of what you're doing. Even if you take a path that maybe wasn't the straightest path, it's still, everything has something to teach you, is how I try to think about it. And that's how we think about often, that's how a lot of surgeons particularly think about when things go badly, like how do I use this experience to do better in the future, take care of better patients' future. So lots of mistakes, but trying to have a mindset around them that they're there to teach me something. Lucer?
Yeah, so I had a question. How do you like get enough sleep so that you can treat patients to the best of your abilities?
Great question. It's especially hard with a toddler, I will say. That part was, or having a new baby, that part was super hard. Worth it, but super hard. We rotate our call, so that's why I do about 2 a month, and then the other times when I'm on at night. So I make sure if I know I'm going to be on at night that I try to be as well rested as I can going into it. But you're sometimes, you're still staying up all night working hard, so sometimes you're still tired. And then I work with my family because I have a toddler, and my husband and our nanny and my in-laws and my grandparents, and like everybody comes to help, because if I go home and I need to sleep to then work that night, like people help me do it, so that I can be the best physician that I can when I'm working overnight. Trauma is particularly different. Not every surgery, not every part of being a doctor works at night. Residency usually includes some amount of nights, so you get used to doing it in some way because somebody's got to take care of people in the hospital at night. But ours in particular has a lot more nights. So you kind of try to figure out, do I need to exercise? Do I need to sleep? Do I need to eat? How to take care of yourself so you can take care of your patients. Great question. Sukita?
My question for you is, I don't know if I think you've answered this, but
Yeah.
in the surgery, what parts like do you do? Like what parts are you like part of? Like do you do like what is exactly like trauma surgery? Like do you remove trauma from certain parts of the body, or do you just do it from their whole body? How do you remove the trauma?
Great question. So trauma usually is somebody's injured in something, whether they have a blunt injury, which is you're in like a car crash or a fall or something like that, or you're hit by a car, or a penetrating injury, which is more when you think about it, if you were like shot or stabbed usually. Those can hurt. Most of what I do is in the chest and in the abdomen. I do some stuff in the legs, but like if you break your leg, then I'm going to call the orthopedic surgeons. But if you have bleeding in your legs, most of those things cause bleeding or they hurt the organs on the inside. So that's something that I would do surgery for, to help stop the bleeding that you have on the inside of your belly or your chest. Or if, say, like it pokes your intestines and that needs to be fixed, then that would be something we do. But I also take care of the whole patient. So sometimes I'm taking care of a person that I'm not operating on, but they have lots of injuries to lots of parts of their bodies that other people are operating on. Their brain is really badly injured, their legs are broken, and I'm managing their whole thing. Who takes priority, who gets to go to the operating room if they're very sick? Do I let them go? How do I manage the ventilator? So those are things I'm trained in, kind of both of those things, both the operative management and then managing patients that are hurt, even if I don't operate on them, to help get them through their hospitalization. Great question. Hars Miran, I think I said that wrong. I am sorry, Mr. Singh.
It's okay. I also had a question about how hard the transition from your undergrad was to med school and how like that went.
Med school, low key, probably easier than undergrad. Most med schools are pass, not pass. As opposed to undergrad at Cal, which was definitely not that. You know, that was a pretty competitive grade system. Once you get into med school, it's quite a bit smaller as well. I was in a fairly large class at UCSF, and I think we had like 150 per class. So it's a much smaller environment. You get to know people, and I found it much more rewarding to study when I was able to think like, this is what my patients are going to know, and I'm learning about the body, and this is cool. I didn't really like physics and OChem. I knew I needed to do them to get the prerequisites, but that's like not what I wanted to do with my life. So I found med school like very rewarding on that front, because you're actually learning about how you're actually going to take care of these people. So that part was pretty cool. The first 2 years at least were pass, not pass. And then like very stressful when you have to take the qualifying exams. So then, you know, you pay it back somewhere. Somewhere somebody's going to get some kind of, you know, need to get some assessment of you where you're going to be judged against other people. But overall, I found med school probably easier and less stressful, although not stress-free by far. Jasleen.
What do your average work days look like, and how often do you get time off of work?
Average work days are very variable. If I'm on service, I'm usually here from 6 a.m. till 6 p.m. That's if I'm on during the day. If I'm on overnight, it's 4 p.m. here to 8 a.m. the next morning. And then the other days I'm doing stuff like this, talking to patients, working on my paperwork, working on my research projects. I'm one of the fellowship directors, so I'm interviewing people for fellowship positions this afternoon. So the other days fill up with kind of all the other parts that if you don't work at a university when you're a doctor, you aren't necessarily part of what you're doing. But because I work at a university, it kind of, those are the other parts I have to do, my service and my teaching and my clinical and my research. And so those things fill up otherwise. Rachel, last question, I think.
Okay, I'm sorry.
That's okay.
Do you have any advice, like looking back at your own experiences and like cutting time for like becoming a doctor in general, like the whole journey?
Cutting time, like trying to make it shorter.
Or like a short, like for it to not be like super long. Like, is there anything that you look back on and you're like, oh, like I didn't have to like do all this?
Not really, not for surgery. So I think if you don't, if the time is a thing, then you don't go into something that is a long residency, right? Like neurosurgery, 7 years, orthopedic surgery, 7 years, pediatrics is 3, medicine's 3. So, you know, if you have other goals and want to do other things, then I think you can make those choices. The only time that's like a flex time in there is the 2 years I took to earn money and take the MCAT and like apply. And I think that was a really valuable time to make sure before I did that investment that I did really think like, okay, I do think I want to be a doctor. I've worked with these doctors, like I understand it. So I think all of that was helpful. And everybody, you know, every day I'm learning. Every day our patients have something to teach me. So it kind of never stops.
Okay, thank you.
Thank you.
All right. Well, thank you so much, Dr. Robles. This is great. It's such an interesting specialty. So thank you for all the pictures and for telling us your story. We very much appreciate it.
Thank you guys. And thank you for being here.
All right. We're actually going to move on to our last speaker. So unfortunately, our speaker for 11 was unable to be on. She was ill today. So we're going to jump to our last speaker for the day. We'll end half an hour early, so we should get out of here about 11:30-ish. So I want to introduce a physician specializing in obstetrics and gynecology. Dr. Hailey MacNear is an OBGYN at Sacramento Women's Health. And a little fun fact I always like to share, Dr. MacNear actually delivered my son 7 years ago. So welcome, Dr. MacNear.
Hi, everybody. This is my second year doing this. So I don't have a PowerPoint for you, so I'm just going to kind of talk at you. And I'm happy to take questions. What other speakers did you have so far, like specialty-wise?
So today we had Dr. Sisson, who's the Yolo County Public Health Officer, Dr. Robles, who is in trauma surgery, and then we heard from an internal medicine doctor on Monday and some medical students. So we're
Oh,
just getting started. The program just started on Monday.
okay, great. All right. Well, my name is Dr. MacNear, and I am about 10 years out from training. So I graduated from residency in 2015 and from med school in 2011. And I am in private practice, OBGYN. So it's a little bit of a different model than probably most of the people that you've heard from so far. I work in a group with 6 other OBGYNs, and we take care of our own patients. So, you know, you would come to our office, we would take care of you during your whole pregnancy. And then when you go into labor, my pager goes off and I drive to the hospital and deliver your baby. So it's kind of old school. There's not too many practices left that work like this, but I really love it. It has some cool things about it that make it really rewarding for me. And I'll kind of talk about that a little bit, but I just want to talk about OBGYN in general first. So we are a 4-year residency. So you would finish medical school and then apply to be an OBGYN, and then it's 4 years. And we are at our heart a surgical subspecialty as well. So OBGYN encompasses obstetrics and gynecology, and gynecology is the surgical specialty. So we do a lot of procedures. And then obstetrics has one surgery really associated with it, which is the C-section. And so some babies are born via C-section, so you learn to do those. And then we, like many fields, have subspecialties. So OBGYN, if you just did 4 years of residency and then went and got a job, which is what I did, you're considered a generalist. So I do a little bit of everything. I see people from 12 to 92. I do GYN, I do surgery, I do obstetrics, I do a little bit of everything. But we have 6 major subspecialties as well. We have pediatric and adolescent gynecology, which is a small field, but definitely needed. We have minimally invasive gynecologic surgery. We call it MIGS. And those are people who just do complicated GYN surgery, robotic surgery, laparoscopic surgery. And they basically don't take care of any pregnant patients. They just do gynecology. We have urogynecology, which is an additional 3-year fellowship where you learn to take care of bladder and urinary problems. So incontinence, which is leaking when you cough, sneeze, laugh, prolapse, they do a lot of reconstructive surgery, that kind of thing. We have oncologists. So gynecologic oncologists take care of cancers related to the female reproductive tract. So cervical, ovarian, uterine cancers. They do a lot of surgery, some chemotherapy management, things like that. So taking care of cancer patients. That's an additional 3-year fellowship as well. We have reproductive endocrinology and infertility. So these are the doctors who help people get pregnant who struggle with infertility. And so they do like IVF and all that kind of stuff, which is really cool and a lot of cutting edge technology. That's another 3-year fellowship. We have maternal fetal medicine doctors who do high risk pregnancy. So they take care of moms who have, significant medical conditions that affect their pregnancy, or people who are pregnant with fetuses that have complications. And they usually work in academic centers. So, if you discover during your pregnancy that you or your baby has something wrong with it, a lot of times you would get transferred and have maternal fetal medicine care. So they work as, we call it the patient dyad. So the mom and the baby together. You might hear my dogs in the background. I'm sorry. Let me shut the door. There's 5 of them, but we won't talk about that. Okay. And then family planning. So they take care of complex contraceptive things and abortion care, which we'll talk about in a second. But here in the state of California, we still provide comprehensive abortion care, but that is dwindling state by state as a lot of the laws are changing these days. So let's see. One of the things that's cool about, so what my job encompasses is labor and delivery. So we have patients who are pregnant and can go into labor at any time. It kind of is a rolling basis, right? So people come in, they're really early in their pregnancy, they progress, they get delivered, new people come in, it just kind of goes on and on. And then we have office care. So we take care of patients in the office. We do well woman visits. We do pap smears and breast exams and screening for cervical and breast cancer. We take care of patients throughout the lifespan. And then we do surgery. So all of the surgeries we do are going to be on female reproductive organs. So ovaries, tubes, uterus, cervix, vaginal surgeries, all that kind of stuff. I personally love OBGYN because our surgeries, for the most part, are short. I really like being in the OR, but I don't like being in the OR for 6 hours. So for me, it's perfect. Most hysterectomies take less than 2 hours, and we do everything laparoscopic. And so it's pretty straightforward. And for me, that was one thing that I was really looking for when I was out in all of my rotations, is, you know, finding the thing that I love to do. My job is different every day. I think that's the best part for me. Sometimes I'm in the office, and sometimes I'm on call, and I'm going to the hospital and seeing patients, and sometimes I'm in surgery. And so for me, that variety and kind of long-term relationship with patients is what I really love. We also do a lot of procedures in the office. So putting in intrauterine devices for contraception, doing biopsies, doing pap smears, and all that kind of stuff. We do a lot of procedures. So it's a very procedure heavy specialty. It's also, it's kind of a mix of emergency care, primary care, and surgery. So one of the things about OBGYN is we do have quite a few emergencies. So someone's having a miscarriage and they're bleeding extremely heavily and they show up to the ER, like we would be called for that. Obstetrics has a lot of emergencies in it. So it's kind of a mix, a little bit of trauma and ER, and then sort of more normal, usual office, primary care kind of stuff, wellness visits, and then operating room time. The other thing that I really love about my specialty is that it's mostly normal stuff. Like, I'm mostly taking care of people dealing with normal things about having a female body. Contraception, periods, pregnancy, menopause, puberty, all these are all normal physiologic functions. And so for me, I don't know, I couldn't imagine taking care of back pain and diabetes for my whole life, which, like, God bless the people who want to do that. But for me, it was really nice to sit with patients and talk to them about what is normal for their body. How do we restore normal function for them? How do we help their body do the things that it's normally supposed to do? Pregnancy is a natural process. And so a lot of times we're just watching the normal thing go by and just making sure nothing goes wrong. But I don't really need to do a lot most of the time to help people have healthy pregnancies. Most people are very motivated to take care of themselves when they're pregnant. And so it's actually a really wonderful patient population to take care of. And it's really fun to be part of people's family experience, you know? So there's some patients that I have delivered all 3 of their babies, and it's really cool and special experience to have that. I get Christmas cards and they send me photos of their babies, and it's just cool. It's like a neat thing to be a part of. So OB/GYN in general, we deal with really like a very narrow subset of problems. So the main list is going to be like contraception or preventing pregnancy and fertility issues, vaginal health, hormones, and endocrine. We do a lot of hormonal and endocrine management. So menopause, PCOS, like all these kinds of endocrine problems that people can get related to their hormones. We deal with those. Breast health, sexual health, menstrual issues. So it's a lot of sensitive topics, but I find that, you know, if you're a good communicator, patients are really wonderful at opening up and kind of telling you what's going on with them, and you can really develop a nice relationship with people when they trust you, and you can kind of go through some of this stuff that, you know, there's a lot of information out there, and I feel like it's really nice to have somebody you can talk about that stuff with where you feel like they understand you. The other big things, I talked about surgery a little bit. So at this point in sort of the surgical landscape, the majority of the surgery we do is what we call minimally invasive or laparoscopic. So robotics and laparoscopic is pretty much standard now. So if you go into OB/GYN, that's the type of surgery you're going to learn to do. We use little incisions in the belly button and on the sides, and we put our little instruments in, and it's kind of like a video game. So we can see, there's a camera and we can see what's happening on the screen, and we're operating like that. So that's the majority of the surgery that we do these days. There just isn't that much surgery where we are actually cutting open somebody and going in with our hands that much. Now, the cancer surgeons do much more of that surgery, and then a C-section is still kind of like that. But the majority of our surgery is done minimally invasive. So it's pretty cool. The patients go home usually same day, and they heal really well. So it's a very rewarding type of surgery to do. The other big thing about OB/GYN is we do a lot of advocacy. So for whatever reason, we are a unique branch of healthcare in where our a lot of the services and care that we provide is highly politicized. So there's very few other areas of medicine where there are laws that tell you what you can and can't do to somebody, depending on what state you live in and what kinds of choices that women have about their own reproductive health and the choices they make for their own bodies. So a large part of our profession is fighting for women's rights. It's standing up for our patients. It's taking care of them however they need. It's working in the legislature. It's a lot of advocacy work because it's just interesting because I look at a lot of my colleagues doing other things, and like trauma surgery is not fighting for their right to do trauma surgery. And we are fighting for our right to do a lot of pregnancy and abortion care. And it's a very interesting field to work in for sure. And if you're interested in hearing more about that, I'm always happy to talk about it. And we do a lot of team-based care. So like on labor and delivery, our patients are in labor for sometimes a few days, and we are a team. We have nurses, we have anesthesiologists, we have the OB, we have often doulas and midwives that we're working with, families and patients. So it's a very team-based sport, I like to call it. So you have to definitely be a team player to do well in this field, and you have to like that. So what kind of jobs can you get? So we talked about, I'm a generalist, so I work out in the community, and I see patients in my office, and then I do surgery at a bunch of different hospitals, depending on where someone's insurance wants us to take them. And then I only deliver babies at Sutter here in Sacramento, but some people deliver babies at a couple of different hospitals. You can also be a hospitalist. So just like, I think, did you guys talk to a medicine hospitalist, maybe somebody who works in the hospital? No? Okay. So hospitalist is like you show up and you do your shift in the hospital and you take care of all the patients in the hospital and then you go home. So that is an available option for people who don't like to do what I do, which is, have a pager and be on call and have to get up in the middle of the night and leave your house and all that kind of stuff. Hospitalist-based care is getting much more popular, and there's quite a few jobs for that. So, and a lot of people are really happy with that kind of a job. You can be a specialist, like we talked about. So patients have to be referred to you, and you really only deal with a very, narrow wave of focus, and you become an expert in that. That is what you do. You are an expert in your field. And there's a lot of people who really enjoy that type of job. And then you can work in advocacy and policy. So we have a lot of physicians who decide not to do clinical care and do research, or they work in politics, advocacy, helping make decisions at sort of more of a government or system-wide level, or work in a hospital as an administrator. There's a lot of different kinds of jobs that you can do with this. So sometimes, you'll practice clinical medicine for 10 years of your life, and then you'll move on to something else. So it's kind of there's a lot of options basically available. Your MD will never go to waste. That is definitely true. And then I kind of wanted to just talk to a little bit about like the difficulties of this field. I would say that the hours and sleep schedule are one of the harder things about my job. So when I take call, I'm on call for 24 hours straight. And for us, we take call at home. So unless something's happening, I don't need to be in the hospital, but my pager can go off at any time. And then whatever I'm doing, I have to drop it and drive into the hospital and take care of patients. Occasionally I am awake all night. It definitely happens. And then I always take, like, today's my day off. I was on call last night. Actually, nobody had a baby last night, so I got pretty good sleep. So that was great, but you just never know. So I usually have the day after off so that I can recover if I need to. And the benefit of being in private practice is I get to make my own schedule. So I can choose to do that if I want. But the hours are hard, definitely. And, I think for our career, people retire maybe a little bit earlier because it's hard when you get into your 50s and 60s to get woken up several times a night and get paged and all that kind of stuff. And then I think definitely the stress level as well. Obstetrics is a beautiful field, and it's wonderful until it's not. Sometimes some really sad and scary things can happen to people when they're pregnant and having their babies, and that emotional stress goes to you. So you definitely have some, there's definitely some traumatizing things that happen as an OBGYN, and you have to be able to deal with that stress and have a way that you cope with that. So having a really good social support system is really important. Having things that you do to cope with stress, which is going to be true through all of your educational career. So I encourage you to work on stress management now because it's not getting better as you go. But yeah, I think that those are sort of the drawbacks to this job for sure. It can feel really hard sometimes, but overall it's super, super rewarding. And then I think just the politics of it as well are really frustrating. It's hard to watch patients' rights get taken away in various states. I think all the time about my colleagues practicing in states where they are trying to decide between possibly getting sued and letting their patient die. And that's just a really inappropriate place for a physician to have to be in. And it's really frustrating to watch some of that stuff happen. So I think those are some of the challenges in this field, for sure. But I really like it. So I know that was like just a dump of information for you guys. So if anybody has questions specifically related to OB/GYN or medical school or my career path, anything. Sam, do you call on people or do I call on people?
Either is fine, Alina.
Yeah, just about like your pathway to becoming like was this your first choice, and how, like, what was your school pathway starting from like high school to college to medical school?
Yeah. So I was actually not a pre-med in college. I studied anthropology and psychology and then did a lot of volunteering with peer counseling and with Planned Parenthood, actually. And so then towards the end of college, I was trying to figure out what I wanted to do. And the health careers advisor at my college actually was like, maybe you should consider going to medical school. And honestly, it had never occurred to me before then. And I remember I called my mom and I was like, Mom, I think I'm going to go to medical school. And she was like, oh, that's great. You're so good at paperwork. So, which is true. It's a lot of paperwork. But so then I ended up having to do 2 extra years after undergrad to do some of the prerequisites, take the MCATs, do all of that stuff. And then I went to UC Davis for medical school. And then you do rotations in medical school where you kind of go through all of the different specialties. And I think it was very obvious to me that OB/GYN was like the place I belonged. Kind of how I got into it was, women's healthcare. And I think I was most nervous about not liking surgery, but it turns out that I did. And so, yes, it was my first choice, and I got to match and stay at UC Davis. I actually grew up in Davis, so it's my hometown. So it was really nice to be able to stay here and have family support through all of that training. And then I went right into private practice out of medical school. So I definitely had a little bit of a non-traditional route. I was definitely not pre-read. And I think for me, it was helpful because it makes you a little bit maybe different than other people potentially, but also I think because I was studying things I really liked, it was not as, I don't know, the early part of college was not as stressful for me, I think, as sometimes pre-med can be. So, yeah.
Sarah?
Yeah, so I was wondering if you like can give a like the average number of how much time do you spend on like patient care versus administrative tasks like paperwork and stuff like that?
Oh, well, I mean, the administrative, so I don't do any administration, like as far as like hospital administration or whatever, but you have to write notes. I mean, the biggest amount of work that we do is documenting what we do all day. And you can get very efficient. We use electronic medical records, and actually AI scribe is coming online soon. So we'll be able to just talk in the room and the AI will just write your note for you. So I'm excited for that coming up here in the next few years, probably. But I would say I'm pretty efficient and a lot of our visits are pretty short. So on an average clinic day, I see somewhere between 25 and 30 patients a day, but I'm usually home by 5:30 and I have all my notes written. So I'm pretty efficient, just kind of get through it. For me, I run so we're a small business as well. So I also run my business. So there's a lot of time that gets spent on like business stuff, like dealing with our staff and making, we have meetings and we have to do financial stuff and things like that. So that actually, I think, is the most administrative time that I do. I don't do any teaching or working with residents, but I know a lot of my colleagues do. So I would say that probably 80% of my time is clinical. I'm mostly just doing clinical work.
Thank you. That was a great answer.
Yeah.
Sankita?
For you becoming a obstetrician, how long did it take for your residency? Like how many years was it for you in residency?
Residency is 4 years. So you do 4 years of medical school and then 4 years of residency. So, and then I went straight into working. So it was like, but for me, I also did 2 extra years after undergrad because I wasn't a pre-med. So I had to do like OChem. No one takes OChem unless they have to. So I had to do OChem and like all these things in order to do the prereqs for med school. So that was 2 extra years. So for me, it was about 10 years total since graduating from undergrad. I didn't love medical school. I'm going to be honest. I am a person who, as you can tell, I'm like too social to study in groups. So I had to study alone so that I could really get things in. And so I don't know, it was kind of lonely and boring because I was just studying a lot. And no one goes to medical school to be a medical student, right? You want to be a doctor. So there's things about being a medical student that are just not, I don't know. I didn't love it, but I loved residency. I loved it. It was like great. I didn't mind the long hours. I had a wonderful residency crew that, it's fun to be at work with your friends all day. I learned so much. I had great teachers. I trained at UC Davis. It's a wonderful hospital. So for me, I really loved residency and I was kind of sad when it was over, although I was excited to sleep. I was kind of sad when it was over, but med school was like, I don't know, I got through it. It was fine, but it just wasn't my favorite like period of my life by far.
Jessica.
Okay, so you mentioned that like going on call, like do you have like time to like prepare or like to like dress up when you wake up? And like how exactly far away are you from like the hospital?
Oh, so I live 7 minutes away from the hospital. So I always tell people I live 2 contractions away. I will not miss your delivery. I will be there when they call me. You wouldn't believe how fast I can put a pair of scrubs on. So you just get used to it. I mean, they usually call you with enough time, and then our hospital also has doctors like on the floor there. So if somebody is really just like the baby's coming out, like there's another doctor there who will do it for you, and then while you're driving in. And sometimes I take those shifts and I'm that doctor. So but yeah, like my call starts at 7 a.m. So usually on call days, I'll wake up at 6 so that I can have my shower and have my coffee and just be kind of ready just in case something happens like right at 7. But then I go about my day. I actually usually see some patients in the clinic who know they're going to possibly be rescheduled if I get called into the hospital. And then I usually go in the morning and see all the patients who delivered overnight. That's called rounding. So I go in and see everybody who's already had their babies and discharge people who are ready to go home and check on everyone who's in labor and kind of just see everybody. And then I go to the office, usually for just a few hours, 2 to 4 hours, and I'll see anybody urgent who has something that, kind of needs to be dealt with that day. And then I usually go home for a little bit, or I go back to the hospital if somebody needs me. And then I'm just hanging out at home and I can do other stuff while I'm waiting to get paged, essentially. And I don't know, you just kind of get used to it. And if I need to be there fast, I'm like basically from getting paged to being at the patient's bedside, it's like 10 minutes. So it's pretty quick.
Yeah.
Wait, did you say my name?
Mhm.
Okay. I'm just curious how you made the decision between like private practice and then working at like a public hospital or something like that.
Yeah, it's kind of so for me, I really like the long-term relationships with patients. And so like if you're pregnant and you're my patient, you're my patient. Like you see me the whole time. And I really like that. And I will have patients for years and years, who've known me now at this point for like 10 years, which is really cool. You get a long-term relationship with them. So for me, I like that. The biggest thing about private practice that I think leads to me being super happy in my career is just control over my life. So I decide when I need a day off. I decide how many patients I see in a day. I decide when I work. I mean, I have to take call. We're a group. You have to do your fair share, and I decide what I want to do. If I didn't want to do surgery, I wouldn't have to do surgery. It's just it's a lot of freedom. And I think like me saying like, hey, I need this day off to go and do this, like no one is going to tell me no. So for me, that is like a huge, because this is a hard job and it takes a lot out of you and I work a lot of hours, but having the time that I have to decide what I want to do with it, for me is like what really helps me prevent burnout, because then when I'm in clinic, I'm happy to be there and I'm happy to see my patients and I enjoy spending time with them and they can tell. So I think that's that for me, that is like priceless over, yes, it's annoying sometimes to deal with the business side of things, like having to run things. And I didn't have any business training. So we're, sometimes things happen and you're like, oh, I wish I'd known about that. But, I think for me, it's a really good thing. Now, other people wouldn't want to run a business and they just want to show up to work and, someone else does all of that and they take a shift and then they go home and they, that's totally fine. There's definitely pluses and minuses. And I think there's no perfect job. Every job is going to have something about it that you're like, meh. But overall, like you have to choose what is going to make you the happiest in the long run. And so for me, this is absolutely it.
Okay, thank you.
Yeah.
Kathleen.
Was there a time where you personally felt challenged, maybe like in medical school or during residency, and you doubted whether this was the correct profession for you?
Yeah, I'll tell you, the worst time I had in medical school was anatomy lab. I was super creeped out by the cadavers. I'm not going to lie. Like, I just really thought it was so weird that we were like dissecting a dead person. I don't know. I didn't like it. And so I made it through and it made me wonder if I was going to like surgery, but surgery is different because this is a live person and you're fixing a problem and they're going to wake up and say, thank you. So I think that for me, that was a really hard time and I struggled, but medical school is really supportive. And so I reached out for help. I said, hey, I'm really having a hard time with this. And they set me up with some counseling and it was just nice to have someone to kind of talk to about it. And my group mates kind of knew. And so they let me be the person who like read the instructions. I didn't have to do as much like touching of the, but I think there's always going to be, I don't know that I doubted that it was the right profession for me, but I think I just struggled to get through it, like for sure. And then I also just didn't like GYN oncology very much because like I said, the surgeries are very long. Some of those surgeries are 8-10 hours. And for me, I just physically didn't like being in the OR for that long. You're in a gown and I get like kind of overwhelmed if I get overheated, like just all these kind of silly things that like over time you just are like, this isn't for me, but I don't have to be a GYN oncologist, right? It's like, it was wonderful to see what they do and have so much appreciation for my colleagues who go into that. But for me, it just wasn't the right choice. So I think one of the things about this whole process is everything is temporary, right? Like, and there's very much this, like, you just have to get through the next unit. You just have to get through the next class. You just have to get through the next rotation. You just have to get through the next surgery. Like, and you kind of just push yourself along and know that like, you're going to be able to do it. It's going to be over at some point, right? Like this isn't forever. Right. So then this funny thing happens when you graduate and suddenly you have a job and you're like, there's no like next. And you're like, oh, do I just do this now every day till I die? Like what? It's a little bit of a weird, like, the training is so long, right? Like think about where you are now and then you're going to do undergrad and then it's just, there's always a next thing. And then suddenly there's not a next thing. And so that took a little while to settle into for sure. But I think for me, like getting through those hard times is really just about like, I can do anything for a month. I can do anything for 2 months. I can do anything for today. Like just kind of getting through that. And then you kind of get on the other side and you're like, wow, I just did something really hard. That's cool. So you get to learn about your grit a little bit, which is also a cool process for sure.
All right, we have time for one more question. Sriha or Srija?
Yeah, you had mentioned that you have a business. I was wondering what kind of like jobs or positions you would recommend that's in between medicine and business.
Oh, that's such a good question. Well, the business is like running the practice essentially. So I think any type of business education that anyone has is always going to be useful for this. I didn't really have much of an education when I went into it. I joined a practice that was kind of already like a well-oiled machine. So I've been learning as I go from the people who've already been running it. And then of course there's new things that come out that you have to learn about. But I think any experience that you have outside of medicine is going to feed into your ability to be a good doctor, right? Like studying anthropology and psychology in college was really useful because having a baby is a very cultural experience. There's a lot of really interesting things that are different from culture to culture and how people view pregnancy and childbirth. And so that part of my brain is still very interested in that. I think anything you do can be an asset to you later, right? And you'll have this special skill set that applies to you. And the cool thing about medicine is there's so many ways to like participate. There's so many versions of being a doctor. And so whatever your dream job is, and even if it doesn't exist, you can create it. So I think there's a lot of possibility, and the amount of education and training that goes into it, like none of it goes to waste, right? You're honing your brain and your social skills and your capacity for, just being a helper in the world. And I think there's a lot of ways to apply that. So any job you want to do that you're interested in is going to be useful for you.
Well, thank you very much. Thank you for sharing your story.
Let me drop my email in the chat if
Okay.
anyone has any other questions. You are welcome to send me an email. I think that went to Sam. Hold on.
I can share it too.
You can share it. Okay.
Yeah, I send a recap email to everyone, and I'll share it in that email.
Yes. And then, yeah, I think that's it. Good luck, you guys. You're going to do great no matter what you decide to do. We need more doctors in the world. We really do. And I know it seems like a daunting and long path, but you can do it. You can totally do it. One day at a time, right?
Well, thank you very much. And thank
You're
you everyone
welcome
for being on the call. And we get to leave a little bit early. So have a wonderful rest of your afternoon.
Have a good day, everybody.